I'm Dr. Robert Ward, Chief of MSK at Tufts Medical Center, and I have the distinct pleasure of introducing Dr. Eric Smith, Chief of Arthroplasty at New England Baptist Hospital. Dr. Smith attended Tulane for medical school and his residency in orthopedics at the Tripler Army Medical Center in Honolulu, Hawaii. Additionally, Dr. Smith spent 10 years active duty within the Army, and therefore, thank you for your service, Dr. Smith. And with that, he'll be speaking today on the painful post-arthroplasty hip. Dr. Smith.
Rob, thanks so much. It's a real pleasure today to be with you. Thank you, Hillary, for inviting me, as well as Dr. Ward. Rob and I have known each other for nearly a decade and a half, as I was an attending at Tufts Medical Center when he was a brand new MSK attending. So it's a real pleasure to circle back with your group. So I wanted to focus on the adverse local tissue reactions at the modular junctions of hip replacements. And I wanted to try to blend some of the clinical presentation with the radiographic findings that you all see pretty commonly. So these are my disclosures, none of which are going to be relevant for today's talk. So adverse local tissue reactions, or ALTR, formerly they were called ALVAL, A-L-V-A-L, but now they're called ALTR. They occur because of modular junctions in modern hip replacements are susceptible to movement and corrosion at these areas. And this is described as specifically a mechanically assisted crevice corrosion, or MAC. It's not to get too specific, but it becomes a phenomena of galvanic corrosion, often when you have two different divergent metals that result in a difference in the pH across the region, leading to corrosion. But it's also mechanically assisted because the friction that occurs between the femoral head and the trunnion can result in this additional generation of these metal debris. So this does release metal wear debris in the form of cobalt and chromium, and it results in a very prominent adverse local tissue reaction with an immune-mediated lymphocyte-dominated reaction to the metal wear debris. These are actual intraoperative pictures. Here you can see the black staining on the trunnion, and that results in the adverse local tissue reaction. In this case, the tissue has actually been eroded right through the abductor tendon region, and this would be a histological stain with a predominance of lymphocytes. That's why before it was used to called ALVAL, which is aseptic lymphocyte-dominated vasculitis-associated lesion, but now we just call it the much easier term of ALTR. I'll try not to say that too many times. Okay, so what about it? You know, you have somebody who gets sent to your radiology department with painful joint replacement, you know, about 1.1 to 1.8%. It's going to be from ALTR, from MAC, and it presents very similar to either aseptic loosening of the joint or even infected joint, groin pain, buttock, thigh, trochanteric pain, and also instability. That's also we'll get into that a little bit. Typically, the patients have an elevated metal levels, cobalt somewhere between 5 to 10 parts per billion, chromium you can see there. These are two references that describe this. The tricky part is this, is that the ALTR will mimic an infection quite readily. In fact, you can imagine when you cut into the tissue with somebody with an adverse local tissue reaction, there's pus. It looks very purulent. So you'll see the fluid collection looks purulent, especially in your aspiration. That can be the case. You can see large amounts of soft tissue destruction. And you can see here on the right, this is an intraoperative picture of the actual tissue, the staining, the degeneration, the necrosis. ESR is elevated, but generally less than 32. CRP elevated, generally less than 10. Synovial fluid elevated, less than 4,300, less than 85% PMNs, but certainly elevated. Imaging studies, this is not, this is your realm completely. You get x-rays on these patients to look for other reasons, like, this case in the bottom left is obviously some kind of catastrophic loosening of the femoral component. It's also important based on the x-ray to try to identify the implant. And this is sort of like, if you see a Dodge Geo driving down the road, now, all apologies and respect for anybody that's driving the Geo, today. But the point is that you would maybe say that car doesn't have necessarily a good track record. You just know that. Similar with implants, you can just look at the picture of them, and sometimes the orthopedic surgeons, but oftentimes it's the reps from the companies will know that that implant does not have a good track record. And in fact, that implant may actually have been recalled. So that's what we get from the x-rays. Advanced imaging is also done. Mars MRI is really the workhorse, metal artifact reduction sequence, different levels of sophistication to determine the amount of fluid that you see on this, and to describe the so-called pseudotumor, which is really an ALTR in the sort of more radiographic form. How do you, in general, we're going to get into each of these treatment options. Treatments either, you just need to remove the metal generator. So where's the metal being generated from? Ostensibly, it comes from the femoral head that is moving on the trunnion. So the simplest thing, and I'll get into this a little bit, but it's to remove the femoral head, clean up the trunnion. Typically, this Bovie scratch pad is just taken off the back table and then used as a sanding paper, if you will, to sand down the gross findings on the trunnion. And then a ceramic head, but with an internal titanium sleeve. This is called a TS ceramic head, is implanted, because you don't want to implant a fresh ceramic head onto a used trunnion, because there's small little bumps or asperites on the trunnion, which can then lead to cracking of your ceramic head. So you always have to put a titanium sleeve in a used trunnion situation. However, like this case in which the stem is well fixed, well positioned, you just can't, and there was excessive amount of trunnion wear, you may actually want to remove the whole stem. And that would be a situation where you do an extended trochanteric osteotomy, or ETO. And this is where we basically open up the proximal femur like a clamshell. Got it? So you take a series of drills and saws, and you cut it vertically, you cut it horizontally, and you just crack it straight open, hoping that you don't, hoping that your acronym for ETO doesn't stand for exploding trochanteric osteotomy. That's not a real term, so don't use that in your dictations. So, do you have to remove the corroded femoral stem? You see the corroded stem, do you have to remove it? Well, some literature helps us to determine this. Charlie Ng reported in the mid-2014 region, said about 86 head and liner exchanges that were in situ for 10 years, 35% of these with moderate to extreme corrosion. They did a headliner exchange on all of these, just below a 9% re-revision rate at 3.3 years. So pretty early follow-up. It's not too bad. I think in this situation, it's within reasonable realm of this treatment option. None of the taper-related problems led to the re-revisions. It did highlight the taper scoring definition. I'm going to get into that in a little bit. And there's really no difference in the re-revision rate with the low-grade taper corrosion versus high-grade taper corrosion. So basically, if you encounter taper corrosion, this article would advocate for just doing a headliner exchange. The classification system for the taper corrosion was reported out of core in 2002 on about 231 retrieved implants. It's described as the Goldberg fretting corrosion score. You can see it down here, 1 through 4, and it just goes progressive. 1 is being the least corroded, with 4 being the most corroded. And really 4 just being, the biggest one that I see, if you can see here at the bottom, is flattened areas with nearby fretting scars. I'll explain what that would look like clinically, or at least radiographically. Clearly, that is going to require more than just a headliner exchange, and I'll show you what that would look like. So here's some simple examples. This one here, you may recognize this. This is the DePuy system with the ASR, anatomic surface replacement. This is the multi-billion-dollar recall from DePuy, the metal on metal with a big femoral head. That led to the excessive amounts of metal ion release as well as ALTR. And this was repaired or revised with a new modular head, titanium sleeve. You can't see the titanium sleeve, but this is ceramic. But in this case, the cup also needed to be revised. So that was removed, replaced with a hemispherical shell with multiple screws. And so it's a ceramic against highly crossing polyethylene. Here's an example here. So I don't know if you can squint and see this, but this trunnion here looks like what I call kind of a small finger. It's got some obvious damage. It's got notching. And I think, in fact, it's so deformed that the femoral head has actually slipped off of it. This happens, quite commonly. And so this was revised with an extended trochanteric osteotomy and a full revision. So there are many factors that influence retention of the stem. So did the stem have a good clinical outcome? That's what I was pointing out, is that it's important to understand certain stems that might have a recall, such as like this one from Stryker, certain batches of it. This is called the low friction ion treatment, cobalt chromium alloy head. You can read these in certain Journal of Arthroplasty and others. So it's important to look at the stem and say, has it been recalled? Here's an example of a recalled stem. This is the Rejuvenate. It's a dual mobility. So it's a dual modular. So it's not only modular on the head neck junction, but the neck is also modular within the body itself. The reason why that they're modular, but the reason why they fail is because the pocket that accepts the neck is very thin and can be variable. So it leads to increased motion at this junction, which leads to deformation, accelerates the fretting and the corrosion. So what are the outcomes of the head and liner exchange? In general, they're pretty good. Plummer reported that 25 revisions at follow-up of, somewhere between 5 to 7 years. 2-year follow-up with Harris scores. Anyways, 2-year follow-up. You can see that by doing this head liner exchange, just like I've shown, the cobalt levels reduced almost down to nothing. Chromium levels reduced almost down to nothing. However, there is a high complication rate with this approach because of the destruction of the soft tissue, specifically the abductors. When the abductors are deficient, it leads to increased risk of dislocation, which is a risk for this treatment, as well as infection because the tissue becomes necrotic. So in conclusion, the modular exchange to a titanium sleeve ceramic head results in good outcomes from the local tissue reactions from mechanically assisted crevice corrosion. It's really critical to know the natural history and track record of the stem that you are revising, whether it's recalled or impending catastrophic failure. And you really want to try to retain the femoral component if it's well fixed with low risk of catastrophic failure. I think that's a very solid approach. I'm just going to give you an example. Here's a 56-year-old patient who had persistent right hip pain after a hip replacement at an outside hospital about 1.5 years ago. He developed pain about 6 months post-operatively, sort of relatively early. So you're not really thinking about crevice corrosion per se. It really got worse over the last years. His implant was specifically the Stryker Anato femoral stem. It's a relatively new stem from Stryker, titanium head, and a 40 millimeter head. So you have a bigger femoral head against the trunnion. As far as the rest of the physical exam, it's relatively benign. He's got no evidence of infection, some weakness of his abductors, but otherwise, relatively benign. This is the x-rays. X-rays show relatively well-positioned femoral component, a little bit of varus attitude of the stem, no obvious loosening, some questionable lucencies in the shoulder kind of get your attention, but the acetabular component, appears to be okay. This is a typically, this is an on-growth cup. So you would expect the bone to grow right in. So some of the lucency you see in this zone 1 is a little concerning. So the labs, CRP was elevated, but not too elevated. ESR, again, elevated, but not crazy elevated. Cobalt and chromium levels were elevated, particularly the cobalt. The aspiration was concerning. Initially, there was concern for infection. It was a sterile gray fluid. It looked purulent. But the cell count came back as 700, relatively low. Cultures were negative. Indium 111 scan in this case was performed, which was negative for infection. The MRI shows, difficult to determine the soft tissue extent. Maybe there's some amorphous tissue in this region, but it's it's probably not a high, not an excellent technique perhaps for a Mars MRI. So the patient was taken to the operating room. Intraoperatively, there was a posterior approach, no obvious purulence. The hip was dislocated. There was obviously blackened staining of the trunnion with corrosion debris, and there was pericapsular adverse local tissue reaction with a yellowish thick tissue. The femoral stem was well fixed. So this is what it looked like. You can see there's blackened staining from the corrosion, the yellowish thickened tissue suggestive of a local tissue reaction, adverse local tissue reaction. And a closer view shows that the trunnion, this is some of this on the right side here is some trunnianosis from the bone tam to remove the femoral head. But you can see there is some dulling and blackened staining of the trunnion. So the decision-making was really, should we retain the stem or should we remove it? Based on the Goldberg classification, this is like a 2-3. So it was tough to decide. Ultimately, I was concerned that this metaphyseal stem may not have the best track record. It was relatively early in its release, so I elected to remove it. So third debridement, specimens, the stem was revised. The cup was actually loose as well, so that was revised. And then a new cobalt head was placed on a new stem. So this is the explanted material. It came out relatively easy, and the cup also came out relatively easy. It was revised to a modular implant. So interesting, I did use another modular stem. This is an all titanium-based modular stem with an excellent long-term track record without concerns for corrosion. So it was utilized in this situation. We published this case report. You can take a look if you're more interested. So there are some literature that's even more than just the recommendations I'm discussing. This is from JBJS 2017. I encourage you to take a look at that if you're interested. And they grade some of these recommendations as A, B, and C. Like most orthopedic studies, there's very few A recommendations. Most of it are the B's and C's. In particular, the retaining a structurally intact trunnion on a well-fixed stem is a B recommendation. So well-fixed corroded stems with structurally intact trunnions may be retained at the time of revision. Recommendation B. So here's an example of the catastrophic trunnion fails I'm describing. That would be more of a Goldberg 4. You can see the actual trunnion where the head sits on it has been deformed. And you see this time and time again. This is a purely mechanically assisted crevice corrosion. In fact, galvanic corrosion is occurring at this head trunnion junction, leading to the deformation and weakening of the trunnion. It's quite dramatic. That's revised by a complete revision. In this case, it's more of an exploding trochanteric osteotomy because of the well-fixed bone on the edge of the stem. Again, revised to a titanium-based stem. So full femoral revision, just to conclude with this, is when you'd want to do this in a structurally damaged trunnion, as I've shown here. These metaphyseal engaging stems, again, have a bad track record, in my opinion, and therefore often I'll revise them. The head neck junction, when it's cold welded, should be considered for a full revision because you can't remove the femoral head. malposition components, those leading to dislocation, or those with recalled implants, you should consider a full revision. So this is a conclusion of my talk on this topic. I want to thank Hillary, the OCAD lecture group, as well as Rob Ward in particular for inviting me. This is my email if you have any further questions or follow-up.
So if anybody has any questions right now.
Yeah, hi, this is Dr. Chabra. Great talk. I've been asked to look for these trunnion corrosions, even apply dual energy CT to look at better definition of this metal. Have you had success with imaging? Or is it just presumption that there will always be erosion once you see some ALTR, etc.?
Yeah, it's a great question. I think it depends on the accuracy of your imaging. I would say just based on I would say when I send it over to someone like Rob Ward and I can get, an excellent discussion with my MSK radiologist, I think that improves my accuracy for the patient before. But generally, like where I'm at right now, I'll often send them to like a third-party vendor who gets the Mars MRI, and it can be variable to me what the accuracy is. So I do appreciate that sort of one-on-one discussion with my radiologist in a clinical situation. I think that helps with accuracy. As far as other additional studies, the diagnosis is easy with either ultrasound, CAT scan, or MR when the tissue reaction is large, when the pseudotumor is large, right? There's a large amount of fluid. I just think that when there's obvious pathology, it's easy to see it. But when there's less pathology, like in the last case I showed, it's more of an intraoperative discovery.
Thank you. That's our experience too. A couple of times recently, our surgeon said the prosthesis is loose, and then we did MRI. There was nothing on MRI. So one of my colleagues actually said there's no loosening, and then he was a little mad at us in the sense that you can say there's no ALTR, but you can't say there's no loosening on MR. So, so in fact, on surgery, it was loose, and there was some corrosion of the trunnion.
Yeah, I agree with you. I think that understanding that the most accurate tool we have right now for diagnosis is an intraoperative evaluation. As I showed, that's why I showed that sort of actual real world case report in which, it didn't look that, conclusive on imaging, but was much more conclusive when we got in there.
Okay, if there are no other follow-up questions, I want to thank Dr. Smith for this terrific talk, and thanks for the time, and thanks everybody else for showing up. We had a great showing today.
Thanks a lot, Rob. Appreciate it.